Next up, we will hear from Dr. Alain Moreau about his work looking at the role of circulating microRNAs in ME/CFS pathogenesis. So please join me in welcoming Dr. Moreau.
Thank you very much, Andrew, for your kind presentation. I would like to thank Joe Breen and Vicky Whitmore for their kind invitation to present today our unpublished data. So you will see probably this is the first time today that you will hear about circulating microRNA. So this is another type of beast that a bit special but very powerful. So I hope to convince you about their clinical utility at some point. So here are my disclosures. So I thank the CBLISA Foundation for their support, and also the Canadian Institute of Health Research for the Planning and Dissemination grant that allowed us to organize last year the very first collaborative research conference in Montreal. So I would like to talk to you today about some current challenges. So I decided to start with the challenges because you will see where I'm going. I will introduce you to the Quebec ME/CFS cohort, which is actually the largest ME/CFS cohort in Canada, and also our, I would say, unique approach to profile ME/CFS patient using circulating microRNA, and where this can lead us. And I will finalize with the next step. So what do we know and not know about the etiology of ME/CFS? I would say a lot of things on both issues. So, and this cartoon really illustrates not only ME/CFS, but probably most chronic diseases. So it's clear that there is a predisposition or some initiation genes that will increase the sensitivity toward different environmental factors. It could be viruses, bacterial infections, but could be also some hyperchemical sensitivities that will trigger a disease onset. For a few of the patients, they may have a partial or complete remission, but most of them will continue, unfortunately, so that I'm referring here as a disease progression. And this had the complexity of to identify biomarker for ME/CFS because in the real life, there is no pure entity called ME/CFS. That will be ME/CFS with other comorbidities that will add the noise to identify biomarkers. So this is in the real life, and I think if we do research, we need to develop pragmatic assays that will adapt our findings on the way that we search for biomarkers to this real life and to be more pragmatic. And of course, we can also look for disease modifier or progression of genes and other factors that will further exacerbate the condition of some patients that will bring to a severely affected ME/CFS individual. So the first challenge, of course, and I think the topic has been well discussed so far, is the clinical heterogeneity of ME/CFS, how to select and compare. So you may have different type of apples, different type of colors, but some can disguise even trying to disguise the apple with some another fruit. So it's maybe more complicated. And past, present, and eventually future clinical definition will benefit of the progression or the development of more objective biomarker. One problem also is the fact that often we used to work with small cohorts with different ethnic background, and of course, different omic approach are very powerful methods, but they are very expensive too. So we need to adapt and combine those data, and also pay attention to increase the size of the cohort and to define are we looking for severely ill patients versus early stage patients, because in both cases we might learn a lot of data that we are missing right now. And of course, the presence of comorbidity, influence of sex hormone, and aging will add to the difficulties to really define clinically useful biomarker. Plus the fact that the disease is triggered by different factors, so it's sometimes difficult to understand or to capture at the earliest stage possible the cause and the response of the host of those factors. So one of the challenges is to all with this genome or omics era is to how we integrate all those data together. So Unfortunately, it's difficult to allow patients to visit our labs or clinics, and we pass through them to the different battery of tests that to have a more complete pictures. But we can send samples, and samples can travel relatively easily. Data can certainly travel, and we need to work together at some points to have a better integration of those data, because we can miss some opportunities to discover key findings. So at the end of the day, we will end up with what I'm referring here as a molecular signature. And are we talking about molecular signature to define the risk to develop ME/CFS, or to develop a severe form of ME/CFS, or some symptoms? So we need to work together, because we will continue to discover during the last 10, 20 years, genes, variants, different factors that will be involved and highly associated with ME/CFS, but we need to find actionable therapeutic targets. So this is, I think, the most important thing. Something that can be not just a biomarker, but a clinically useful biomarker, and eventually some of them could be also actionable therapeutic targets. So we put forward, as many of my colleagues, different hypotheses, and we agree that ME/CFS will involve immune function, energy metabolism, and physiological stresses, but we think that one key factor could be the microRNA, which are non-coding small RNA that can bridge genetic predisposition and environmental factors and the phenotypic differences that we observe in ME/CFS. So our primary objective of this research program is to identify circulating microRNA linked to the disease, allowing us to better stage or stratify patients and symptoms across cohorts. And eventually that will lead us to better understand the etiology, determine the molecular, epigenetic, and genetic mechanism associated with the disease, with the ultimate goals to find actionable therapeutic targets. So this is a cartoon that shows you how powerful are microRNA. So microRNA you can detect them in many biofluids, including the blood, of course, and they used to attach to the messenger RNA in the 3' UTR, and doing this association or attachment, they will block the protein translation by creating a duplex that is very stable. And unfortunately, one single microRNA can target up to 200 different genes, and one gene could be a target of more than one single microRNA. So very small molecules, but very powerful, and they are involved now in molecular medicine in different diseases. So to really go and capture the most relevant circulating microRNA, we decided to develop a non-invasive method, or the least invasive method, so using blood. And we developed a test that can reproduce post-exertional malaise. So that was a question that many patients debate and honestly guide me to, if we need to develop a test, can we develop something that can reproduce one of the cardinal symptoms of the disease? So we developed a portable machine, which is machines that provide a therapeutic massage, which is authorized by Health Canada. So this is a machine that normally are not creating any stresses, but on ME/CFS patient, this machine during 90-minute stimulation will create enough stress that will reproduce on a safely manner post-exertional malaise, and I will show you some data about that. So we are taking blood tests before the stimulation and every 30 minutes. And you can see here a diagram that shows during the test, and this is a very recent results. We use a smart vest called ExoSkin that allow to measure different physiological parameters, including heart rate variation. So you see heart rate variation during the stress test, and in orange, this is the patients, and in blue, the LT subject. And this very first pilot trial with the ExoSkin smart vest, we tested identical twins discordant for ME/CFS, so which allowed us to test our system if it was doable to do it. So this machine is an inflatable cuff that gives a very gentle massage. So it's not like a cuff that takes you blood pressure, okay? We're talking about 0 to 4 psi. The machine that gave you the blood pressure is 30 psi, that crunch your artery. So very different. And this is a machine that's been vetted as safe by Health Canada. So this is the typical demographic and clinical data of a Quebec cohort. So we are testing females and males. We are using the same technology with controls, which is a bit demanding because we're asking people to spend 2 hours with us. And more than 85% of our patients are severely ill, so they are homebound. So we are sending clinical nurse at home. And this is the reason to have a portable machine. So the machine is relatively cheap, easy to have an access, and we can test and retest. So, and of course, we are using the traditional standardized questionnaires to evaluate the health status. So in the first part, we use, in our discovery cohort, so we use few patients to determine the most relevant circulating microRNA using the plasma of the patient. So we use the microRNA array Agilent. So we probe over 2,500 mature microRNA, and we end up with 32 differentially expressed. And so far, 12 of them have been validated to a large cohort, which is something very important. So this cartoon illustrate the process to do the validation, and of course, because it's very difficult to normalize microRNA, so we spike in with artificial microRNA from cell ligands, so to make sure that we have something relevant to mention, because I'm not really believing that we can use other endogenous microRNA to do that, because most of them can auto-regulate themselves, so it could be difficult to do that. And the fact that we can use quantitative PCR, this is a tool that can use in any diagnostic lab. So this is, again, a pragmatic approach that if we need to eventually bring on the market a test that can stratify patients, let's use common tools that can be easily be applicable in all clinical labs, private cabinet, or even in the hospital-based setting. I will show you some examples to demonstrate that we have been, I would say, quite successful so far. So we identified the MIR127-3P, which is highly expressed, has been discovered before in ME/CFS Australian cohort. So we replicate in the Quebec population, and we confirm the relevance of this circulating microRNA. And this is what you can see at baseline on the A panel and also after stimulation during 90 minutes. Interestingly enough, this microRNA and the B panel show you ingenuity pathway analysis. So we can identify known and predicted target of this microRNA, and this one indirectly will regulate interleukin-10 through a regulation of BCL6, which is a negative regulator of interleukin-10, and this interleukin is upregulated in cerebrospinal fluid of ME/CFS patients. As you can see, it's also involved through interleukin-10 in the regulation and development of different regulatory of T lymphocytes, so which is something relevant also for ME/CFS. Another example, and this is probably would be very provocative, so I'm the provocation part, but I think I can be provocative as well. So for the MIR145P, because this one is targeting a membranous receptor called CD20, which is the target of rituximab. So of course, if you have an elevation of this microRNA, you will downregulate CD20, which will reduce the response to rituximab. So one thing is, so far I just present you the data about ME versus control, but at unstimulated or after stimulation. But if I show you the next cartoon, you see the results. So the blue bar is unstimulated at baseline, and the purple one is the one stimulated. So you see we have different type of response. We have, for instance, for the first patient, we have a very low expression of this circulating microRNA, while some other patients, like patient number 34, was a very strong fourfold expression at baseline, but a drastic reduction after the stimulation. And we have also the opposites. So for the patient 85, we have low baseline expression and very strong expression. So if you took all the patients that overexpressed with or without an effort, so 2/3 of them are predicted to be non-responder toward rituximab, which bring us about 1/3 of patients could respond to rituximab, which is what has been shown so far. So again, stratification must be also not just include and pool all the patients together because they are not similar. Another microRNA, the MIR-100-5055P. I'm sorry for the name. There's always MIR something with a number. So this one is specifically upregulated after stimulation. And we saw that the higher expressors, so the patients that express very high level of this microRNA, are the ones that present a better mental fatigue score. So as you can see on the B side, as compared to high or normal expressor. And we were very excited about, wow, we have something that improves health. So at least on the mental fatigue aspect. So, and through the Ingenuity pathway analysis, we discovered that this microRNA targeting SLC682, which is a multipass membrane protein that is responsible for the reuptake of norepinephrine. And we also rediscovered a study by Arnold et al. That they tried the drug duloxetine in a clinical trial because this is a known SLC682 inhibitor, and they end up with a different cohort, of course, and using the same tool, the MEF20 questionnaire, that indeed the drug targeting the very same gene improved mental fatigue. So two different approaches targeting the same gene in different cohorts end up with the same conclusion. So again, for us and for the research community, that should be accepted as a kind of replication of past results. This MIR, the MIR-374B5P, is very intriguing because it has been shown as a very low expression in fibromyalgic patients and is inversely correlated with pain threshold. And we saw the opposite in ME/CFS. We are going completely in the other spectrum. We did our own testing in fibromyalgic patients in Quebec using the Cartagen Biobank available to us, and we confirmed that indeed in fibromyalgia patients we have a very, very low expression, but we have a stronger expression in ME/CFS compared to age and sex match control. This microRNA, and again this is a cartoon with EPA analysis, is targeting many interesting genes that are involved in ME/CFS. And I will give you a few examples. So we talk about celiac disease, we talk about the transport of vitamin E. So as you know, vitamin E or alpha-tocopherol are downregulated in ME/CFS patients. It's involved also in the regulation of some genes that involves in mitochondrial disorder, cognitive impairment, anxiety, secretion of dopamine. So now, for the very first time, whatever is your favorite genes or mechanism, we can correlate them or relate them to circulating microRNA. And this is only one. We have 32 like that. So we probably be on the right path, and we need to figure out. So if you see one of your favorite genes in those lists, please come to see me. We are open to collaboration. The last two microRNA are very intriguing because they are associated with endurance athlete. So endurance athlete possess the higher whole blood level of this MIR-186-5P compared to LT control. And again, under stimulation, I create post-exertional malaise. So I'm stimulated like I'm doing exercise or forcing patients. But the patients are sitting in a chair, relaxing, receiving a massage. But they are already showing like they are running a marathon, but they are doing nothing. So again, their system is overreacting and mimicking the net result of someone doing a very powerful exercise. So this is, again, very interesting because if you look in the panel B, this MIR is controlling, again, many genes involved in mitochondrial disorder, EGE response, which I think could be relevant for some patients, the transport of some metals like magnesium, cobalt, and copper, which could be important for many metabolic function. So again, this is very interesting. If not, this microRNA is also triggered by exposure to mercury. So again, you can reach Roma by different roads. Okay, so we need to pay attention that you may trigger something. Here, in that case, because baseline are relatively low, I don't think those patients being exposed to mercury. But in other occasions, patient may be overexposed to mercury, and overdosing or chronic exposure to mercury may lead to the same phenomenon. Okay, so we need to keep that in mind. Another one, and don't worry, I won't go through the 32 because that would be too long, but just again to show you another microRNA associated with endurance athlete. So again, this one is only showing up when we stimulate, so we are stressing the subject, and this one is involved in different aspects. So some of your favorite cytokine, the trafficking of T lymphocyte, riboflavin transport, regulating of sleep, which is, I think, very relevant, as well activation of B lymphocyte, export of acetylcarnitine. So whatever is your favorite gene, I think we can figure out something that we can establish some collaboration. Why those microRNA? How can we use them? So we can use them to have a different stratification. So the blue and orange color here mean a different response between the stimulation after 90 minutes and at baseline. And as you can see, you don't need to see the number, but just showing the colors, you see that we can classify or stratify the patient in 5 subgroups. Those subgroups that are associated with different comorbidities. And you see sore throats are increasing over time, especially in subgroup 4, and we have different symptoms. So for us, it would be very interesting to identify other predisposition factors that associate with some symptoms associated with ME/CFS. Also, as the symptom reported after the stress test, those patients behave differently, especially subgroup number 5, where we have mental fogginess, vertigo, dizziness. So different behavior, different type of response using our 9 microRNA so far that we use as a selection panel. And I will show you how powerful this classification is so far. So for instance, we can use about different delay activities. So the lowest one is in group 1, the highest one is group 5. You can check for general fatigue, mental health, using the DSU cognitive. So there's a significant difference in some subgroups. In terms of, we reanalyze all of our biochemical data using those patients, and we observe, especially by comparing the group 4, the one that's showing the less symptoms, as opposed to the group 5 that the only one present mental fogginess, vertigo, dizziness, which is very specific for this subgroup of patients. And we look about a well-known molecule called thrombospondin 1, which is an anti-angiogenic factor. And you see the drastic elevation of thrombospondin 1 as opposed to group 4 going in the opposite direction. And we think that in that group, the effort, the stress that we impose to the patients induce a vasoconstriction in these patients. So we are following that because if it's proven, we can eventually figure out a way to block this effect using inhibitor for CD36 or CD47 or one specific integrin. So they have 3 receptors to target. So knowing this new molecular stratification can open the door to more specific therapeutic approaches, knowing that we are now entering in the era of precision medicine for ME/CFS using this new stratification eventually. So just to finalize quickly, we play around with the plasma, and this is, I'm referring this experiment, this is a brand new experiment, a Ron Davis-like experiment, using cellular electroscopy assay bioimpedance, where we apply the plasma and we look if the plasma itself can trigger abnormal response. In that case, we use a cell line, Jurkat cell line, which are immortalized T lymphocyte. And you see in this panel that when we use control plasma, we have not much change. Same if you use plasma from idiopathic scoliosis patients. But when we use ME/CFS, we have a nice dose response. So we tested, and this is, of course, again, one experiment by picking up patients from each of these functional subgroups that we developed with the microRNA. And you see there's 2 that are above control in black, and they have 3 below. So we don't know yet what is really responding, but it's quite unlikely that would be antibodies or autoantibodies, because when we apply the stress, so the stimulated plasma gives us a different response. and it's impossible that the antibodies are disappearing after 90 minutes of stimulation. So this opened the door to use this platform to screen for eventually possible therapeutic compound when we will know what we are doing. But again, that replicates in part what Dr. Davis have been previously shown, that there is something in the plasma, and we fully agree with this comment. We did the same thing with twins, identical twins, and as you can see, we worked so far with concordant and discordant twins, and we saw a difference between the identical twins based on questionnaire and, whoops, sorry. So, and you can see, although they are identical, they are not part of the same microRNA subgroup. So, which explain also the difference in terms of symptoms, which make a lot of sense. With the concordant twin, using the exoskin, you see the change before, so pre-test and after the test. So it's hard to say that we really changed something on the heart rate variation, but we observed that a strong decrease in the post-stress compared to the pre-test in the REM sleep time. So we don't know yet what it is, but we presume that this is really induced by the post-exertional malaise that we apply to the patient using our stress test. So what are the next steps is, of course, we need to perform more validation. We will be happy to collaborate with all of you to test your own patients and to provide our samples that if you are interested about metabolomics, proteomics, our samples are available to further complement what we can learn and know. And eventually, working together is, I think, the only solutions to bring forward and find solutions for ME/CFS. So finally, I would like to acknowledge the participant and the family, because this is a very demanding test. It's not obvious to ask, especially on severely affected patients, even though that they open the door, their home, that we perform the test. We are doing also retest of the patient, and even if they experiment and they know that the test will induce a post-exertional malaise, they are willing to participate. So we never put anyone in the hospital or needs to call 911, but nevertheless, we induce a post-exertional malaise. And I would like to thank the support of the Sibylla SA Foundation, CHR, a lot of ME/CFS organizations in Canada that support us, also patients across the world, because we are lucky to obtain support from donation as well as participants, and also all my team members and my collaborators. Thank you very much.